Okay. Okay. Alright, let's start then. So, like I said, there are two types which you're probably they're going around so you can see. So the yellow one, which is the fine one, it's the narrow bore, it's used for enteric feeding, and then we have the wide bore one, which is used for to relieve obstruction. So there will be three parts to an NG tube station. One will be to insert the NG tube, the other will include documentation, and the third will be to interpret chest x-ray and to say whether it's in the right position or not. So like with all procedures, the complications, can anyone name, like tell me a few complications of NG tube insertion? What else? I haven't got that one, but yeah. Distress and discomfort to the patient, mucosal damage while it's inserting it, and then placement into the respiratory tree. So the equipment that you would need is non-sterile gloves. You need the NG tube, of course, some jelly just for some lubrication to ease the NG tube to go in. You need a glass of water for the patient to allow the patient to take a sip, because it's the mechanism is the trick between waiting for them to take a sip and then you push the NG tube down. I put a tape in, but you don't really need it because you can just make the measurements from the NG tube. You need a 60ml syringe. Bradford, it's purple coloured syringes. I'm not sure whether it's the same in Leeds. You need a vomit ball, a spigot, and a pH indicator strip. Okay? So measurement of is called NEX, neck, and it's basically from the nose to the earlobe and to the xiphoid, okay? And normally it would be around 50, 60, so just make a note of that once you've measured it, because that's how hard you're going to push the NG tube down. So like with all procedures, you need to introduce yourself to the patient, explain what's going to happen, and gain verbal consent. Make sure that they agree. I said agree a stop signal because sometimes it can go down the respiratory tree and you need to, the patient may start coughing, may start turning blue, and they might not be able to say that they want it out or they need to stress, so you need to agree a stop signal beforehand so that you know when to stop. So, simple, it make the patient sit upright, assess the nostrils, which one you're going to go in through, and then lubricate the end of the NG tube with the jelly, and then start pushing the tube in through the nostril. Once it hits the back of the throat, they normally tell you that it hits the back of the throat, you need to ask them to take a sip of water and hold it, and then when you tell them to swallow, that's when you start pushing the NG tube down. You need to remove the tube if you see, like I said, any signs of respiratory distress. If they start coughing, they start turning blue or pale, just stop straight away and take it out. Obviously in the exam you'll be doing it on a dummy, not on a real patient, but just mention it to the examiner that this is what you would be assessing for in reality. So once the NG tube is in, so you've got wherever it was 50, 60 you've marked to, you can tape it. Don't take the guide wire out, but attach the 60ml syringe to try and get some aspiration. Try to get at least 1 ml so that you can then test it with the pH slit. Now the ideal pH you want, it needs to be acidic so that you know that it's in the tummy. So it should be between 1 to 5.5. If the pH is between 5 to 6, you need to get it checked by a second competent doctor or person who can put NG tubes in before you start feeding. And if not, the best check is to get a chest x-ray to confirm the position. So secure the tube down, and then the next part is documentation. So in the exam they'll expect you to document what you've done. So main points that you need to write is date and time, who was present, if you had a chaperone at the time or not, confirmation of the next measurement, whether you achieved any aspiration or not, what was the pH reading, and whether it was checked by a second person, and whether you confirmed the position or not. If not, you need a chest x-ray. Okay? Has everyone got that down? So, how to confirm on a chest x-ray. So what are the main things you look at is you need to identify the carina, that's where the windpipe splits, and see if the tube dissects the carina. You need to identify the diaphragm and see whether the tube passes below it, and whether you can see the tip of the tube below the diaphragm. Okay, so these are your 5 checks that you need to do. So I've got an x-ray, and I want you to tell me whether it's in the right position or not. Yeah, that was easy.
Well done.
I couldn't find any more images, and you couldn't get any. So if you just try just Google and see images I like, it's a really good slideshow picture that would come. Okay, now try to show. Let me just get to the page. Right, okay, we'll talk about male catheterization now. Okay, some of the reasons that you would want to catheterize, I put male on the top, but male or female patients. So if you guys tell me some reasons that you would catheterize somebody. Yep. Very good, yep. Think of female patients, when would you use catheter on them? Yep. Another thing that only females can do. Yeah, obstetrics or childbirth. So these are some of the reasons that are common in Bradford, shall I say. Retention of urine, bladder injury, childbirth, elderly patient or incontinent, and they're confined to bed, bladder weakness, and this is quite common because I worked in a urology ward, and usually chemotherapy, if they've got bladder cancers, they get what we call BCG, is the name of the drug, through the bladder, through a catheter. So that's another reason. Equipment, different trusts have different equipment, so please familiarize yourself. Obviously you would be having the Leeds equipment, but once you start working, you'll see that different trusts have different types of things. They have everything in one pack, which Bradford does, which is quite convenient. Sometimes you have everything in different places. You need to go and grab all of them and take it in a trolley. So make sure that you know what trust you're working at and which method which equipment they use. And the packs that they use. These are the main things that you need to make sure that you take with you when you're catheterizing a patient, and that you're not, in the middle of the thing going, oh, I need to get another saline flush, or I need to get this. So that's an important thing. So the most important thing would be to get a catheter pack, which contains a kidney dish, a small pot, cotton ball, sterile towel, sterile gauze, and some gloves. Male catheter 12 or 14. Saline sachet. In a female, you could use 12 as well. Usually we use 12. Male can go up to 16 as well. Saline sachets, 10 ml full syringe of water. That's for the inflation of the balloon, as you can see there. That's what it looks like when you inflate it, when it's inflated. 10 ml of Instella gel. Now that Instella gel is used to numb the area so that when you insert there's less pain. Catheter, obviously. I think we've got the catheter pack. But in Bradford you have everything in the pack, but I think in Leeds you need to get catheter. This is basically the catheter pack, and this is the whole catheter stuff in here, which is used in Bradford. So basically it's got a catheter in it, and the rest of the stuff. We'll pass it around and you can open it and have a look what's inside. This is just the catheter pack, so that's the one on the top that I've mentioned. So again, I'll just ask you guys to go through step by step that you guys think should be the order, and then we'll go through it. So first thing again, what would you do? Introduce yourself, yep. And you confirm the patient identity. Make sure you've got the right patient, the right Mr. Khan. Then you gain consent, plus you explain the procedure. You need to explain to them where you're putting the catheter, because sometimes patients don't know what catheter means. They don't know which part you're inserting into, so you need to mention what you're actually doing, where you're going to put the catheter in. It can be very difficult if you have a patient who doesn't speak English, and then you need to find somebody who can explain. Plus you need a chaperone. Make sure that you mention that you need a chaperone. And as for, shall I say, advice in future, when you're working, actually make sure you have a chaperone. Even if you have to wait 20 minutes, unless the patient is in retention and they cannot wait, I would advise that you always take a chaperone with you. You can wait 10 minutes for a nurse to find a nurse. Make sure, and also make sure you document when you are writing in the notes that you had a chaperone, and please take their name as well. There's no point writing there was a chaperone. So you could put nurse Sarah or sister Deborah, whatever. So introduce yourself, confirm patient identity, consent, explain procedure and why you're doing it. Sometimes patients say why you're putting a catheter in, unless they're in retention, that makes sense to them. But you know, in other situations, you might need to tell them that it's going to help relieve whatever. So you need to say why. Again, that's easy points: wash hands, and then you make sure that you have a sterile trolley. I think we got a lesson. I think in first year or second year we were told how to clean trolley and all that. So I think that might not be a part of the in the exam. They might say you have a catheter pack open and you need to start from there. So they might cut half of it out. So make sure you read the question and you're not there thinking, oh, I have to open a new catheter pack and I'm starting from scratch. So they might have it all half done for you. So make sure you read the question. So unwrap the equipment onto a sterile trolley in an aseptic manner. So you're holding the corner of the blue wrap drape and make sure that you don't touch the inside. You pour the saline over the cotton balls that you have. That's the first thing you could do, because once you've got gloves on, you can't touch anything on the blue sterile wrap there. So make sure that you do all this before you go onto it. And the next thing is very important, that you position the patient how you feel that they'll be comfortable and you will be comfortable, because you need to make sure you can reach and adjust the bed height before you start, because you can't just in the halfway go around adjusting the bed, because then you'll have to change your gloves again, wash your hands again. Obviously if you've done that, then you can go back and do it, but it's best that you don't stop in the middle in an exam and say, oh, otherwise mention it in the exam that you did something wrong and you would restart it again. So make sure you position your patient appropriately and tell them that they need to take their undergarments off, and then give them something to cover themselves up while you are arranging the trolley. And then again, wash your hands and put gloves on. So this is the catheter pack. So you can see the cotton balls, the blue drape that goes onto the patient, and some gauze so you can hold genitalia with. That's that one. Let's see what is the next slide. Okay, so I've got a couple of pictures because it's very difficult. We're not in a clinical room where I can show you how to do it. So what I've done is I've put different pictures on. I've written what you would do on one slide, so I might be flicking back and forward. So first thing you would do is drape the patient. So I'm going to go back to that page and show you. So that's how you place the drape. So you can see that I've placed a kidney dish there. So that's ready if the patient stuff. I know it's quite. I found these slides. They're really good slides actually. Let me just go and show you the other one. So you can actually see everything on here, very clear. So that's the cleaning process. So make sure you clean one way and then the other way and then the middle. So that's how you do the cleaning. And the third thing is the instiller gel there. So you insert 10 mils of instiller gel. So if I go back, if I've missed anything. Yeah, the gauze is there for your for your sake really, to hold the genitalia and then do any of the maneuvers. Some people don't use the gauze because they're wearing gloves, so they just use their non-dominant hand, which is your usually left hand for people who are right-handed. So you use the left hand to hold the genitalia, and for the right hand, that's your clean hand, so you clean everything with that. You hold the catheter with that hand, and that hand does not touch any of the genitalia or any of the part of the body of the patient. So that hand should be kept clean. Now feeding the catheter in, so that would be after you've given some time for the Instella gel to work. Usually we say 5 minutes, but in reality we only give the patient like 40 seconds and we're just like, let's just put the catheter in, we've got other jobs to do. So feeding the catheter in, and then you pass through the prostate, that's when they feel the pain and resistance for yourself. So you will feel that it's not going any further, but that's because you've just passed the prostate. The urine should start draining. That doesn't always happen. When that happens to yourself, don't think you've got it wrong, or I'm trying to advise you for future. I'm not just giving you something for OSCE, because you will be starting in August, and that might be the first thing you need to do. That might be the first thing on your job list, is to do a catheter. So I'm trying to advise you some things which are not just for the OSCE, it's for life. So the thing is that you might not see any urine draining, and that happened to me on the first catheter I did on my surgical placement. So I was like, what should I do? I went and called for help. I didn't think of anything else at that point, so I'll just tell you what you should do instead of just getting your SHO. So if there is no urine, then what you can do is get a bladder syringe and try and drain the urine, because sometimes the Instella gel that you've used could block the tip of the catheter. That's what usually happens. So that's just an advice for future. But in an exam situation, you would say that if you would put the catheter in to the end, and then the urine should start draining. Inflate the balloon when there is urine draining. If there is no urine draining, please do not inflate the balloon, because that could mean it's not in the right place. So never do that unless you are confident that there is urine draining. So that's when I used the bladder syringe to make sure there was urine. Then you can inflate the balloon with 10 mils of saline, and then you warn the patient, sorry, that's a spelling error there, pain. If they have any pain, they shouldn't have any pain when you insert the water, because it should be in the bladder and the balloon should be inflating the bladder, so it just shouldn't have any pain. But if they do, just stop, and you might have to reinsert it then. After inflation, you withdraw the catheter, because you need to make sure when you pull it out that it's the balloon has been inflated and the catheter wouldn't fall out. Then you attach the draining tube and the catheter bag, and you replace the foreskin. Oh, yeah, that's very important. So that's just a picture showing you the catheter there going in. And that's the end of the catheter. You can see when the urine starts draining. So if there was no urine, then you would put the bladder syringe where the urine's draining from, and then pull the syringe. And that is used for the 10 mils of saline there, that tube there, the green tip. Now exactly there. Okay, some important points. I thought that they're really important for future as well, not just for the OSCEs. So when you actually do a catheter, it's good to check how much there is in the drain, and that will be the documentation when you go back and write in the patient's notes that you put a catheter in, what type of catheter you put in, who was the chaperone, blah blah blah, and then you might have to say when you bladder scan them how much there was in their bladder. So that's another thing that you need to know about. If you do not see any urine draining, that's the thing that I've put in, and that's what a bladder syringe looks like. It's got a different tip to a normal syringe that you use for flushing and things. So that's, as I said, the gel can block the catheter tip. If you have any concerns, then get your seniors involved. Always good to get them involved. They're very helpful. And you record the residual volume. Some of the complications, as I mentioned here, is pain, misplacement, infection and trauma. So just that could be one of the questions that they ask in OSCE, what are the complications of putting a catheter in. Pass it over to, but I'll just send you the catheter. You can open them up. Yeah, fine, we're not going to take them back. Yeah, so. Fine. Actually, do you want me to open them up? You're fine. Okay, so the next one we're going to cover is suturing. Had anyone had any practice on suturing? Okay. Unfortunately, I couldn't get any suturing packs today, but it's one of the skills that you actually need to go down and practice. It's going to be very hard for me to explain, but I'll try my best. So, in typical OSCE, there'll be 3 parts to the question. You'll be asked to suture. You'd be asked to work out the dose of local anaesthetic for, I don't know, it might be a 55-year-old lady man, or a 70-kilogram man. And then you'll be asked, the third part would be to actually give the local anaesthetic. So typical suturing pack will include forceps to hold the skin, needle holder, and scissors. You won't have the catgut suture because they're different sizes, so you would have to get that separately. So this is just what the suture looks like, and I thought it was quite useful for me to just explain where you actually hold it. So you need to hold the needle in the distal part of the body, so it's around here, okay? That's where you hold it with the needle holder. So you'll be just asked to do simple interrupted sutures. Does everyone understand what I mean by that? So if you've got a cut in the skin like that, what it simply means, you go in the middle first, you do 1 stitch, cut it, and then you go between the end of the stitch you did and where the cut starts, and do 1 in the middle, and then again from the other side. So that's how you do the interrupted sutures. So what you do, it's known as 1 bite and 2nd bite. So this picking up 1 part of the skin is known as the 1st bite, and you need to go quite deep. You don't need to go, I think you'll be penalised if you go quite superficial. So you need to go quite deep in the skin. I would say about that much. So that would be your 1st bite. And then your 2nd bite would be from the inside upwards, okay? And then when you need to tie it, it's throws that you do. So you have to hold. It's really difficult, but it is all about practice that you need to do. You simply throw 3 throws away and tighten it, and then you throw 3 throws towards you and tighten it, and then 1 away again, and that's it. So it's 3, 3, 1. You need to remember. Okay. So dose of local anaesthetic. So there are 3 that you need to know about. Bupivacaine, which is 2 milligrams per kilogram. Lignocaine is 3 milligrams per kilogram, and lignocaine with adrenaline is 7 milligrams per kilogram. Okay, so the technique to give local anaesthetic is you need to make sure that it's not in the blood vessel, because you don't want it to go into your heart. So what you do is you put the needle in and withdraw the syringe slightly, just to check if you get any blood in the syringe itself. If you get blood, you would stop. So in the OSCE, just say that if I would get blood, I would stop and start again. And then you inject the local anaesthetic whilst you withdraw the needle out, and that's the technique. So to summarise, as I've mentioned before, guys, that there's some easy marks in OSCE station that you can grab hold of, even if you forget to do things in the middle, is hand wash. So make sure that you show the examiner that you're washing your hands clearly, and then read the question, because as I mentioned before, maybe half they don't want to see half of the clinical skill that you need to do. So they might not want the whole of the catheterization, they might want half of it. So make sure that you read, because there will be other questions related to it which will occupy the rest of the time that you need to complete it. ABG, if there is a station this year again, make sure that you at least mention the Allen's test, and they might tell you that you don't need to demonstrate the Allen's test, so just mention it. NG tubes, as Sandila said, the pH and the X-rays is very important, because this is, it's a thing that shouldn't happen in hospitals, which is feeding through an NG tube into your lungs. It's a no-no situation. So make sure that you mention the pH and X-rays, and you, if they show you an X-ray, you know how to look at the carina and where the NG tube tip is. In catheterization, always remember it's very difficult for us because we're doing a lecture on clinical skills, whereas clinical skills is to be done in a room. So you should know how to differentiate between your dirty and clean hand. So I couldn't actually show you how you would do it. So asepsis is the most important in catheterization. So you need to remember this is your dirty hand, this is your clean hand. And in suturing, as Zio said, it's just practice. It's practice. And you can all do it. It's all about being safe at the end of the day. I remember last year we had a station. It was simple, just take some blood, and then we were presented with some blood results, and the patient's hemoglobin was, I think, around 7, and it was about describing red blood cells, something like that. So it's like most stations will be divided up into 3 parts. So just remember to read the question and do them all. Thank you for listening.
Hopefully that's not how we're ending this. You guys are all awake.